Hi everybody, I'm Steve Walker and I'm with Fleischman Hillard International Communications. And on behalf of bioMérieux, I'd like to welcome you to the second in a series of 3 webinars that are designed to educate clinicians involved in sepsis management on the role of procalcitonin. Today's webinar will focus on the emergency department physician perspective and will be led by Dr. Rakesh Engineer. Dr. Engineer was appointed to the Department of Emergency Medicine at the Cleveland Clinic in 2001 and currently serves as the discipline leader for emergency and undifferentiated care at the clinic's Emergency Services Institute. Dr. Engineer is board certified by the American Board of Emergency Medicine and became a fellow in the American College of Emergency Medicine in 2004. He is active in the Lerner College of Medicine of the Case School of Medicine and developed the curriculum for the Emergency Medicine and Undifferentiated Care Block. His primary clinical interests are in severe sepsis and septic shock, and he also has interest in evidence-based emergency medicine and residency journal club. He's also a course director for the Emergencies in Medicine conference held annually at Park City, Utah. So now for the next 30 to 40 minutes, Dr. Engineer is going to share information about procalcitonin and how it can help emergency department physicians ensure a better outcome for their sepsis patients during the first 24 hours at the hospital, which arguably is the most critical time for these patients. And then following the presentation, he will welcome your questions. And with that, I'll turn it over to Dr. Engineer for today's presentation.
Hello everybody, my name is Rakesh Engineer and the title of this talk will be the use of procalcitonin in risk stratification of sepsis syndromes in the emergency department. The first slide will show you my disclosures. I work as a consultant for Brahms, bioMérieux, and Cadence Pharmaceuticals. Goals and objectives of today's talk are to review the definitions of sepsis syndromes, the epidemiology of sepsis syndromes, review scoring systems for sepsis, and the majority of the talk will focus on procalcitonin as a biomarker, and then we'll touch off on some implications for management. Some of the challenges facing us as emergency physicians dealing with severe sepsis is that sepsis typically presents with non-specific findings and may be difficult to detect in a busy emergency department. Oftentimes, delayed recognition leads to inappropriate care and less than ideal outcomes. Hospital crowding as well as a recovery audit contract add to our disposition challenges. And finally, there are very few tools to guide our risk stratification. The first section of the talk will describe the definitions and epidemiology of sepsis. SIRS, or Systemic Inflammatory Response Syndrome, consists of 2 out of 4 criteria, specifically abnormalities of either temperature, hypothermia, or hyperthermia, heart rate greater than 90, either tachypnea or hyperpnea, and finally leukopenia or leukocytosis. However, the presence of systemic inflammatory response syndrome does not prognosticate any increased mortality, as we'll see later on in the talk. Further definitions, SIRS becomes sepsis when a source of infection is suspected. It becomes severe sepsis when a presence of organ dysfunction is revealed, either in acute renal failure, an elevated bilirubin showing dysfunction of the liver, thrombocytopenia, new onset of hyperglycemia, or delirium, amongst other organ dysfunction. Septic shock manifests itself when a patient's blood pressure becomes unresponsive to 2 fluid boluses of 20 to 30 cc's per kilogram. And specifically, I think it's important to be aware that this is either below 90 millimeters or 40 millimeters below their baseline, which I think is more evident in the coming age of electronic medical records, where it's easier to find out what a patient's baseline blood pressure has been. The incidence of sepsis has increased over the years and now rivals that of cancer, acute myocardial infarction, as well as AIDS. This shows that the incidence of sepsis mortality is comparable to that of acute myocardial infarction at approximately 215,000 compared with acute myocardial infarction of 235,000 per year. The costs of sepsis are staggering, roughly $22,000 per case of severe sepsis, with a vast majority being admitted to the intensive care unit. The next section of the talk is titled Sepsis Detection and Risk Stratification. Dr. Emmanuel Rivers stated within his landmark paper that the early identification of patients with insidious illness makes possible the early detection of goal-directed therapy. I think this highlights the need for early detection, which leads to early management and eventually improved outcomes. The first biomarker to be considered in risk stratification of sepsis syndrome should be lactate. This has been used for over 10 years now, with Dr. Rivers estimating that 2/3 of his patients were enrolled based solely on an elevated lactate. This leads to initiation of the early goal-directed pathway and placement of the central venous catheter. Lactate also has a high specificity for locating increased mortality. Dr. Nathan Shapiro was able to show that an elevated lactate shows an increased mortality of up to 18%, roughly 1 in 5 patients with mortality during that first hospitalization. Sepsis can also be risk stratified based on sepsis type. Patients with suspicion of infection but no SIRS criteria in that same study showed a mortality of 2%. Those who had SIRS criteria had a similar mortality of 1.3%. When organ dysfunction was present or hypotension was present, mortality increased significantly. The next 3 slides will look at sepsis scoring systems, covering the mortality in the emergency department or med score, followed by the CURB 65 score and the rapid emergency medicine score. As you can see on the first slide, the mortality in the emergency department score is a scoring system developed at Beth Israel Deaconess Medical Center, looking at 9 different criteria with varying points for the presence of each factor. These are then totaled and stratified into one of 4 groups. The CURB 65 score was developed for risk stratification of pneumonia, however has been applied and evaluated in the sepsis world as well. This is a simple 5-point score with the presence of each variable attributing 1 point. And finally, the rapid emergency medicine score is a 6-variable scoring system with 9 possible scores for each variable. I believe that this becomes quite complex with some time and somewhat difficult to calculate on the fly. Now, looking at the 3 scoring systems, they all compare favorably with increasing mortality as each score goes up. And this was a study by Howell out of the Academic Emergency Medicine from 2007. The med score was the score that was most heavily validated, and in one case it has been shown that lower scores, particularly those under 15, do tend to underestimate the mortality, as can be seen in the predicted mortality in the black boxes on the left side of each column. And only over a score of 15 do they overestimate mortality. The performance does become worse when early goal-directed therapy is not practiced in that setting. The next section is titled Sepsis Early Management. Slide 24 references Dr. Anand Kumar's study of a retrospective review of septic shock patients across 14 intensive care units in 11 hospitals. Within his study, he found that patients who had septic shock, only approximately 80% of which received antimicrobials, taking up to 6 hours on average to receive them. Patients who received their antimicrobials in the first hour had a 79.9% survival. However, each hour of delay was associated with a decreased survival of almost 7.5%. I think this provides strong evidence that early antibiotic therapy affects the mortality of patients with septic shock. As I think most everyone is now familiar, early goal-directed therapy provides the most significant improvement in mortality in patients who have either severe sepsis or septic shock. Here, procalcitonin fits in nicely with this plan of therapy in the identification stage. As we'll see in the next section, procalcitonin helps the clinician to stratify patients early in their clinical course. Patients with a procalcitonin level greater than 2 should have a concern for severe sepsis, and even higher levels should raise even greater concern. When procalcitonin levels greater than 2 are shown, I think that the physician should look closely for evidence of organ dysfunction and pay special attention to blood pressure for evidence of hypotension. This should also prompt the clinician to initiate early antibiotic therapy and place early central venous access. As with lactate, serial measurements of procalcitonin may be even more useful to accurately risk stratify these patients in the first 24 hours in the hospital. In this next section, I will describe procalcitonin. Procalcitonin is a prohormone of calcitonin. It is cleaved in several areas to make calcitonin. Procalcitonin is manufactured by numerous cells throughout the body after inflammatory stimulation. High levels are very suggestive of bacterial infection, and these may rise as early as 2 to 6 hours after the initial insult. This helps to identify patients early in their clinical course and risk stratify them into categories of sepsis, severe sepsis, and septic shock. People are also able to monitor a therapeutic response over time. The biomarker has a half-life of approximately 20 hours period. It is also generally not affected by renal clearance issues. The current FDA claim is that the Vitus Brahms procalcitonin is an automated test for use on the Vitus instrument for the determination of human procalcitonin in human serum or plasma using the enzyme-linked fluorescent assay technique. It is intended for the use in conjunction with other laboratory findings and clinical assessment to aid in the risk assessment of critically ill patients on their first day of ICU admission for progression to severe sepsis and septic shock. That's quite a mouthful, and to summarize those statements, it is a biomarker that has been validated for risk stratification of sepsis syndromes on the first day. What are some of the characteristics of a biomarker that would be useful for identification and risk stratification of sepsis? I think the first is that the biomarker should have a rapid rise, something that I think most physicians are familiar with in our practice of risk stratifying chest pain patients, particularly looking for a biomarker that rises as soon as someone has onset of chest pain. Very similarly, we would like to see a biomarker for sepsis that rises shortly after the infectious insult. The graph on slide 32 shows a bacterial challenge at time 0 with various biomarkers showing an elevation. Interleukin 6 and 10 both show more rapid elevations, however have the problem of falling approximately 6 hours afterwards. Procalcitonin has a rise approximately 2 hours later and stays steadily elevated over the next 48 to 72 hours, and it shows an earlier rise than CRP. Second characteristic should be that the biomarker would be accurate both in terms of sensitivity and specificity. In this study by Dr. Beat Mueller, procalcitonin was shown to risk stratify patients, and it shows that procalcitonin has a logarithmic rise that's concordant with the progression of sepsis syndromes. Looking at the same data, this is a receiver operating curve that shows the performance of procalcitonin when compared to interleukin 6, CRP, and lactate. For those people in the audience who are not familiar with receiver operating characteristic curves, a line from the point in the left lower corner up to the top right corner would essentially depict a coin flip. Anything below that line would represent a very bad biomarker, and anything coming up straight up would show that there was a high sensitivity at specificities close to 100%, and then would typically flatten out across the top. And as you can see, compared to the red line which I've drawn, that procalcitonin very closely mirrors that. This is that same data pointing out in a different format that procalcitonin has a very high likelihood ratio of 14.8 and a negative likelihood of 0.12 for the differentiation of sepsis versus no sepsis. The other biomarkers of interleukin 6, CRP, and lactate do not perform nearly as well. And the third characteristic of a biomarker for sepsis that we would look for would be the ability to risk stratify patients and thus assist us in developing management strategies. In this study by Harbarth, he compared the ability of procalcitonin, interleukin 6, and interleukin 8 to risk stratify patients across sepsis syndromes. Looking at the graph on the left, there's a greater degree of separation between SIRS, sepsis, severe sepsis, and septic shock as compared to the graph in the middle, as well as the one on the right showing the interleukins. Now, procalcitonin not only works and stratifies patients in the intensive care unit setting, but has also been validated in the emergency department setting. In this study by Dr. O, she was able to show a semi-quantitative procalcitonin was able to risk stratify patients between SIRS, sepsis, and severe sepsis, specifically with significantly higher levels in severe sepsis when compared with both SIRS and sepsis. And when comparing the semi-quantitative procalcitonin against both Apache scores and SOFA scores, procalcitonin was found to be, again, more beneficial and accurate.